Good morning, everyone. Thank you for being here. It's a huge honour to be the first genetic counsellor to present for the Canadian Academy of Health Sciences, to my knowledge. It's nice to be the first member, but I hope of this professional group, but I hope I'm the first of many. So obviously my clinical training is going to inform what I talk about with you this morning. So just to give you a brief idea about what we'll be covering, I thought I'd start by making sure we're all on the same page, a bit of a level set about where we're at in terms of the genomics revolution that's been so widely touted, particularly with a focus on where we're at with regards to the prevention of common complex disease. And then we're going to talk a little bit more specifically about using genetic information as a way to engage people in behaviour change to reduce their risk for common complex disease. And then at the very end, we're going to talk a little bit about reconceptualizing what genetic counseling is. Okay. Oh, God. Every time I look at this, it makes me feel so old. That date says 2000. This is the White House announcement of the first draft of the Human Genome Project. And the little bit that's underlined there in red, in case you can't see it, says that this will bring in an era that will bring new ways to prevent, diagnose, treat, and cure disease. So that was nearly 20 years ago. And so new ways to prevent, has genomics delivered on that yet? So a few years ago, this was in 2015, this is actually a press release that was attached to an article that appeared in The Lancet by the then president of the Institute of Medicine, Victor Zhao. And in this article that this press release is about, Victor's talking about how personalized medicine is going to save the US economy $600 billion, yes, that's right, $600 billion over the next 50 years by helping people to engage in behavior changes that will reduce their risk for cardiovascular disease. Okay, so this sounds like a lovely idea. In fact, this concept, I would say, is one of the golden grails, if you like, of genomic medicine. It's, to use genomic information as a way to get people to reduce their risk so that we don't spend all this money on these common conditions. But the problem is, we've got a ton of data just showing that it just does not work. So what you're looking at here is a Cochrane review from a few years ago, from 2016, which is literally compiling all of the studies that have been done that have tried to use genomic or genetic information as a way to engage people in exactly that, trying to get them to change their behavior to reduce their risk for common complex diseases. And the upshot basically is that, yes, does not work. This has led some commentators, not me amongst them, I'm not a cynic, to say that where we're at in terms of precision medicine is at this peak of inflated expectations on Gartner's hype cycle. So the technology trigger is the precision medicine concept. So I'd like to get us nicely, swiftly through that trough of disillusionment. I'd like to push us right up to that lovely plateau of productivity if I can. Okay, so let's start in that endeavor by thinking about the studies that I was just briefly flashing up for you on the screen there, those trials that have tried using genetic information as a way to try and engage people in behavior change. So observations that I've made about them is that the interventions that have been studied have tended to involve a simple unidirectional transmission of information, that is, from the clinician or healthcare provider to the patient or participant. That's basically it. There's been very little emphasis in the interventions that have been described on linking the role of genetics to suggested risk reduction strategies. So it sounds, from the way the interventions are described, like what's happening is the researcher or the clinician is saying, you have an increased risk for diabetes, change your diet, without actually connecting those two things together in a very coherent way. And there's been little or no attention to emotion. Okay, so now I'm going to talk a little bit about how I think we could be using genetic information to engage people in behavior change. So just to follow on from that last idea, and we know this, there's lots of theoretical approaches to thinking about how we get people to change their behavior. And so based on that, applying it in this context, this is what we arrive at, basically. So we need to embed genetic information in a coherent story of etiology that gives people a sense of control or agency, that their actions actually matter. Like if you're telling somebody genetics, what they hear is, oh, well, that's it, then I'm done. And so anything that you say subsequent to that is not necessarily going to stick if it's not coherently linked to that genetics piece, right? And we need to give people an opportunity to address emotions that can act as a barrier to behavior change. If somebody's feeling desperately guilty, that maybe they feel it's their fault they've got diabetes because their diet has been so appalling for the last 10 years, then they're going to have to confront those emotions to make any changes to go forward. And I'm going to blow your minds by suggesting that genetic counselling might be able to help us with this. I know you may be sitting there thinking, well, how on earth is talking to people about what the chances are for their kids to develop an illness they have going to help people with changing their behaviour? This makes no sense. Okay, so first of all, we need to talk about then what genetic counselling actually is, because I know there's a lot of misconceptions. People tend to assume it's an intervention that's almost synonymous, if you like, with genetic testing, that genetic counselling is something that you do when you have genetic testing, or that genetic counselling is literally a conversation with prospective or current parents about what their chances are for their child to have a condition that's in the family. And sure, genetic counselling can be applied in those two different situations, but that's literally just the tip of the iceberg. This is the definition of genetic counselling from the largest and oldest professional association of genetic counsellors in the world. Genetic counselling is a process of helping people to understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. Right, so this says nothing about testing. It says nothing about pregnancy. It's a deeper, sort of more existential purpose that we're getting at here. Further, we tend to think about genetic counselling as being an educational or informational endeavour, right? And there's definitely an informational component, but it's called genetic counselling for a reason. Okay, so the informational component, however, basically involves helping people understand causes of illness, not just the genetics. If you're talking about complex disorders, like most of the common ones, cardiovascular diseases, diabetes, mental illness, which is my specialty area, then you cannot talk about the etiology of these conditions without talking about the roles for both genes and environment, as you will see in a second. So we help people understand causes of illness and how that might relate to recovery or reducing risk. And we can do that bit we were already mentioning, talking about chances for other family members to develop illness. And then there's the counselling component, and that involves identifying and addressing the guilt, shame, blame, fear, stigma stuff that often attaches to people's explanations for cause of illness. So that's all very nice in an abstract way, but perhaps it might be helpful if I share with you a couple of case examples to really get the point across about what genetic counselling can look like. These cases, two of them, are drawn from my own clinical experience, and so they do focus on psychiatric disorders, but I think it works really well because they are common, complex conditions. So the first case is about somebody I always call Jane. Obviously, I've changed a couple of things here and there to protect her identity, but so she came to see me for genetic counselling at age 50. She had a diagnosis of bipolar. She had a job that she absolutely loved, she was really good at, and where she was out. They were writing articles about her in the company newsletter, you know, all that self-congratulatory, look at us supporting people with bipolar disorder, that kind of thing. But she was having to take time off work because her mental health wasn't great, and that was frustrating to her. So she was having episodes of depression, which meant that she couldn't go in. She came in for genetic counselling because her daughter had just turned 21, and to use her words, she said, well, it's going to happen any day now, as in her daughter was going to develop bipolar too. So she was really quite anxious about that for her. In genetic counselling, one of the fundamental questions that you always ask people before you do anything else is to explore what people's existing explanations are for cause of illness. And the reason that that's so important is that we know if you don't do that first and you just say, hey, well, actually, we know it's genes and environment acting together, see you later, that what happens is people go, oh, really? Oh, yeah, oh, that's very interesting. Thank you. Yeah, that makes a ton of sense. But they don't integrate it into their own existing explanation for illness. So this is a critical part. So when I asked Jane, she said, well, it's genetics, isn't it? And I said, well, do you think there was anything else? And she was like, no, it's genetics. So I tried a different tack and I asked her, was there anything going on for you around the time that you first got sick? And she started talking about a list of awful things that shouldn't happen to people in a lifetime, let alone in the space of 6 months, which was really what had happened to her. So she was able to tell me it happened around the time of onset, but she hadn't associated it with the reason for onset. Okay? So This is a model that we use in genetic counselling so it's nice to say genes and environment acting together, but again, there's nothing really to hold on to there. So we developed this visual analogy with working together with people who have lived experience of psychiatric disorders and their family members, and we've got research showing how effective that it can be for people. The concept is that everybody has a mental illness jar, and that in order to be actively experiencing an episode of illness, that jar has to be filled up to the top. And there are two different things that you can fill your jar with: the genetic vulnerability factors, which are represented by the yellow balls here, and experiential or environmental vulnerability factors, which are represented by the triangles. So we talk with people about how you start out with a certain amount of genetic vulnerability. That's going to vary between individuals. But that what can happen over time is that those experiential factors can add into the jar until such a point that it may get full. And so we use evidence-based examples of the kinds of things that can contribute, environmentally, if you like. And so we did that with Jane. So we talked with her about genes, environment, how it works together, and I had to try really hard to get her to hear what I was saying. So it took 2 or 3 goes, approaching it in different ways, and eventually she kind of stopped dead, and I could literally see the blood draining out of the bottom of her face. And I asked her what was going on. She said, "So you mean to tell me it's not just genetics?" And I was like, She was utterly horrified. She said that she would not have been okay with anybody knowing that she had bipolar disorder had she understood that it was caused by anything more than just genes, for fear that people would blame her for a condition. Right, so you may be wondering, why on earth did you do this to the poor woman? She comes in all empowered, and what are you up to here? Well, the goal is that, first of all, she's really worried about her daughter. I'd like to try to get her anxiety about that down. Number 2, she's having to take time off work because she's not doing well with her own mental health. As it turns out, all she was doing to protect her mental health was taking psychotropic medications, which she'd been prescribed by her family physician 20 years prior. Right, so, and there wasn't really very much else going on. So I was hoping that if I could shift her model of understanding about cause of illness, we might be able to do more to protect her mental health. So I tried talking to her about those things like, well, those things that happened to you that contributed to perhaps to onset of illness, those are nothing that anybody could blame you for. And hey, isn't this great news? If it's not entirely genetics, it means that your daughter's not guaranteed to get it. Yay. Wasn't really sure that she heard any of that, and then it got even worse. So the end of the session, I'd thanked her she was receiving genetic counselling in the context of a research study, and we'd pre-arranged that she'd complete some questionnaires with one of my team members. I had somewhere else to be. So it was one of those classic moments, hand on the door handle. And she said to me, the other thing is, if we'd known it was anything other than just genetics, we would have had more children. And she burst into tears. So I tried to stay and talk with her about that. She did this. So the only reason that she said anything at all was because I think she knew she wasn't going to have to talk about it. So you may be wondering, why on earth is she telling us this awful story? Well, it's because of what happened next. I should also mention, so we didn't just leave it there. We talked about how if that's the explanation for cause, then maybe there's things that we can do to protect mental health better for the future. So what you're looking at here is an extension of the model that I was showing you earlier. The protective factors are literally rings that stack on top of the jar, making it taller so that the jar can accommodate more of that environmental stuff without getting full. So we spent some time talking about what those things might be for Jane. So in addition to just taking the psychotropic medication, we talked about sleep, nutrition, exercise, good social support networks, finding more effective ways of managing stress, for example. These are all protective factors. And the outcome was basically a month, by the end of the month, where we followed up with people to see how they were doing. She had a psychiatrist for the first time, was trying a new medicine, which looked like it was already helping her more than the previous medication had. She was working hard to get better quality sleep. She was going for a walk every day and eating more healthily. She'd actually lost 5 kilograms by the end of that first month. And this is my favorite bit. So she'd started mindfulness meditation classes with her daughter. Okay, so this is genetic counselling, right? And these are the behavioural change outcomes as a result of the conversation that we had together. So for those of you sitting there in the audience thinking, well, that's all very nice, but her explanatory model for her condition was genetics. What about if somebody's thinking that it's all environmental? What then, huh? I got you. So let's talk about Bob. So Bob was somebody that I saw a number of years ago now when he was in hospital. He had a diagnosis of schizoaffective disorder, and he was in hospital because he'd recently attempted suicide. So he was not doing well psychiatrically. He was fighting with his psychiatrist about medications. The psychiatrist obviously was saying, if you want to get better and you want to get out of here, you're going to have to take this stuff. And Bob was like, And there was a lot of headbutting going on and not much therapeutic, which was frustrating for everybody involved. So at the beginning of, genetic counselling sessions, I like to do a little bit of chit-chat, get to know you business. And so I was doing that with Bob, and it turned out that he actually had a graduate degree in psychiatric genetics, like me. So I have a PhD in psychiatric genetics, so we had a complete nerd-out moment. I was like, were you at the World Congress on Psychiatric Genetics in this year? And anyway, so it was a lovely little bonding moment, but it triggered me to make some assumptions. And one of the assumptions that I made was that I knew what his explanatory model for his illness would be. I thought it would have something to do with genetics. So I almost didn't ask him my fundamental question about what do you think caused your illness. However, my reptilian genetic counselor brain managed to kick in, I guess, and I got my question out, and his answer stunned me. He said, bad life decisions. So I was literally like, but what we were just talking about, I don't understand. So he said, well, no, I understand that at the level of the population, genetics is really important. But in my own specific case, it was this thing that I did, that thing that happened to me, the fact that I smoked way too much pot when I was an adolescent. That's why I have psychiatric illness. So as genetic counsellors, one of the things that we do as well is take a detailed, in the context of psychiatric disorders anyway, is take a detailed psychiatric family history. So I did that with Bob, and he was able to, he gave me the information, of course, and I drew it out, and it turned out that both of his parents had had psychiatric illness, not the same specific label diagnosis as what he'd had, but closely related. So I drew that out, I showed it to him together with that jar model concept that we were just looking at together, and he dissolved into a puddle of tears. He was able to articulate for me that he said, I can see for the first time that perhaps it's not all my fault. He talked about how he felt a weight of guilt had been lifted. And so, I think most of us in medicine, go into these kinds of professions because we want to help people. And so, yes, wow, yay me, this is me helping someone. But he'd been living with this diagnosis for 20 years, and this took me an hour. And the really sad thing to me is that so few people have access to what I was providing for him here. We imagine that other people in the healthcare system do this for people. They don't. It's not happening, and we don't do it because I think we're so focused on crisis management in the context of psychiatric disorders, and medication changes and so on, which is of course desperately important. But to get at these deeper level existential things can be really profound for people. So already that's nice, but when we followed up with Bob one month later, he was out of hospital, he was taking his psychotropic medications, and he was doing much better psychiatrically than he had been in years. And when I asked him about what was going on there, he articulated it so beautifully. He said, once I understood that there was a biological contribution to my own illness, then biological treatment started making sense. I mean, it sounds obvious, and it is obvious once you're told because it's obviously true. But I needed to be told, and we don't. Anyway, I won't belabor the point, but you get the idea. We don't address this enough, and it's important. Good. So basically, Bob's behavioural change was that he started taking his psychotropic medications. Jane's changes were more that she was engaging in these lifestyle types of things. So how did this? So if I've already told you that genetic information doesn't get people to change behaviour, what's going on here? Well, so what we're doing through providing genetic counselling is providing people with that sense of control, that their actions matter. We're linking the explanation for cause of illness with the risk reduction strategies we're suggesting. And we're giving people an opportunity to acknowledge and address their emotions. So with Bob, he felt profoundly guilty and shamed that he felt it was his fault he had schizoaffective disorder because of his use of pot when he was younger. With Jane, she had to confront her regret about not having had more children, which was associated with her causal explanation for the condition that she had. So these explanations for cause of illness have really deep and powerful connections emotionally. So Just a couple of little bits and bobs for you here. We've got lots of data from looking at what the outcomes are of providing genetic counselling for people. So what you're looking at here is a measure of empowerment from pre to post genetic counselling. And you can see well, maybe you can't actually because it's over the line, but the p-value is very small, so it's statistically significant. But, like many of you, I'm sure, I don't actually get that excited about p-values. I get more excited about d-values, about effect sizes, because I'm not interested in a significant effect between groups if it's so small as to be clinically insignificant. So what you're seeing here is a d-value of 1, which is, I didn't realize actually that d-values came that large. This is making a difference that patients are noticing. We've got subsequent evidence of that. Lovely quote. It makes it feel less like I've made mistakes and I've not necessarily caused my mental illness, and there are things that I can do to help manage it. And then addressing emotions, that's the other part of things that we've been talking about. And so just another beautiful quote about that just came out in a paper we published. It lifts some of the guilt and shame. It makes you feel a little better that you're not a bad person. That's really one of the things with psychiatric disorders. People feel it's a moral failing in some way. And this really gets at some of that stuff. I don't know what happened with the sequencing here. Sorry about that. So if genetic counselling can lead to behaviour change, does it then, in turn, like behaviour change that's aimed at helping people reduce risk, can it then actually result in better health outcomes? That's the next obvious question, right? And so, what we do know is that genetic counselling leads to better adherence to medical management recommendations in the context of paediatric and cancer settings. And from my group, our latest data is showing that compared at least to no intervention, we haven't done anything else yet, this is all brand new stuff, genetic counselling leads to better mental health outcomes. And so again, that's a d-value which is sort of in the moderate range, which is not to be sniffed at. Just another quote to share with you there. I think genetic counselling has helped me reduce my hospitalisations. For the most part, I've stayed out of hospital. I've been to the hospital a couple of times since genetic counselling, but in the past, I would have been in the hospital for a month at a time, Now I'm only in the hospital. When I had been in the hospital, it's only for a couple of days. So we're actually actively looking at this right now. We're using PopData BC to look at the frequency and duration of psychiatric hospitalizations between people who did and did not receive genetic counselling and stuff like that. So it's kind of interesting stuff. So, okay, let's get back to this concept about, what is genetic counselling then? Because I think most of us initially come at this concept with the idea that it is about genetic testing or it's about talking about chances for kids to have a particular condition. So we're just going to blow up some of our perceptions of what it is, where it's delivered, and who has access. So not very much, just a little bit. We're just going to talk about those things briefly. Okay, so we tend to think about genetic counselling as being an educational intervention. Hopefully I've showed you that it's more than that it's called genetic counselling for a reason. And we tend to think about it as being something that's really only for people who have a strong family history, want to talk about chances for kids to be affected. Maybe they look like they have a genetic syndrome of some kind. Maybe they want genetic testing, or they're pregnant or planning a pregnancy. And of course, you can apply genetic counselling in any of these contexts, but that's not it. There's more to it than that, as hopefully I've managed to illustrate for you with the 2 case examples I shared. Another thing is that we tend to think about it as being an activity. That is, any conversation that any kind of healthcare provider might have with a patient about about genetic testing or about chances for kids to be affected. Well, I think it's important to point out that it is a profession. Hello, I'm a genetic counsellor by clinical training. We have board certification in Canada. We're looking at regulation and so on at the moment. So it is actually a profession as well as you could consider it as an activity, I suppose. So just to sort of go a little bit further in terms of what genetic counselling is, here's the definition I showed you earlier about what it actually is all about. And to me, that falls beautifully underneath the umbrella of psychotherapy. So I regard genetic counselling to be a highly circumscribed, time-limited form of psychotherapy. What you're looking at the bottom here is the definition of psychotherapy from the American Psychological Association. So for me, that top definition falls beautifully underneath that bottom one. Okay. We can talk about that later. You can challenge me if you like. Okay, so genetic counselling, let's think very quickly about where it's delivered at the moment. So at the moment, genetic counselling in Canada is really stuck in tertiary care silos. It's, something that you have to be referred to. You have to go to a university medical centre for the most part. But I think that, if we're thinking about really trying to reap the benefits of the genomics revolution, then, through the kinds of activities that I've been sharing with you today, I think we really need to rethink that model. I'm really intrigued by the idea of integrating genetic counsellors into multidisciplinary care teams across medicine, but including primary care, and actually through a Genome Canada funded large-scale applied research project, we're doing just that. So we're integrating a genetic counsellor into a primary care practice team, and we're studying outcomes of that, both for the team and for the patients of that practice. So by doing that kind of thing, a genetic counsellor could help the team by identifying potential pertinent genetics issues, who needs to be evaluated for long QT syndrome, for example, or hereditary cancer syndromes. And they can facilitate genetic testing in all the obvious ways that you would think of. But as well, we could be helping patients to engage in behaviour change to reduce their risk for common complex disease in the manner that I've been sharing with you. And then, that ties beautifully in, I think, to the concept of who has access to genetic counselling. So currently, in the historical model that we've used in Canada and North America more broadly, really, is that genetic counselling is something that we tend to think of and offer to people who have or who are at risk for single gene disorders or conditions for which genetic testing is available. And of course, we can be useful in those situations. But, as Victor Zhao was talking, that thing I shared with you at the beginning about how, the economic modeling for cardiovascular disease was showing that the US economy could save $600 billion over 50 years by getting people to engage in lifestyle behaviors to reduce their risk for that condition. Well, shouldn't we be at least thinking about using this because it actually works? Whereas we know genetic information doesn't, genetic counselling might. So maybe we should be thinking a little bit more out of the box or broadly about how to employ genetic counsellors in Canada. So just to finish, so genetic information alone does not produce behaviour change. We know this. It's a fact. There's plenty of studies showing it. By addressing emotions and providing a sense of control, genetic counselling can produce behaviour change, it looks like. Genetic counselling, when done properly, should be, in my opinion, psychotherapeutic. And that's really my big take-home, I think, is that it would be really great if we could start thinking about integrating genetic counsellors throughout medicine, including primary care. And I'm going to leave you with a lovely picture of my team, most of whom are genetic counsellors, and without whom none of the stuff I've presented for you today would be possible. So thank you very much.
No problem. Thank you so much. So we have time for questions. So please.
I'm Dawn Stacey from the University of Ottawa. Thank you for your presentation. So in my research, I do research on decision coaching. And one of the key terms that and we're doing a Cochrane review right now on this, and we're looking at genetic counseling as well. So one of the key terms that comes up is non-directive.
Oh, no.
And so I just wondered if you could talk to, in your perspective, is your perspective on genetic counseling non-directive?
Oh.
Because it seems like with psychotherapy, it could be more directive.
Oh, do you know, as you could probably tell from my reaction, I despise the association of the term non-directive with genetic counselling. Let me explain the historical origins of the association of the terms. So back in the day, so genetic counselling as a concept arose in the 1940s, and there was some other pretty shitty things happening in the genetic space around that time. And so non-directive was a term that was applied to genetic counselling as a concept, as a way of distancing the practice from the eugenics movement. Okay, so it was thought of specifically as a term that mattered the most when what you were doing was talking to people about their childbearing decisions, right? So in reality, today, in clinical practice in genetic counselling, genetic counsellors routinely tell pregnant patients, you should be taking folic acid, right? Because we know it reduces the chance of neural tube defects. In cancer settings, we talk with patients fairly directively, if you like, about what screening might be the best for them given their health goals and so on. So I think that the term non-directive has outlived its usefulness. It literally applies to the specific context for genetic counseling where we want to make clear we don't tell people whether or not they should have kids. Right? That's literally the only way in which non-directiveness applies meaningfully to genetic counseling. Okay. Thank you.
So thank you for your very, very interesting presentation, Ilham Emami, McGill University. I would like to see how do you link the life course approach within genetic counseling modeling?
How do we link the what, sorry?
The link of life course approach into the genetic counseling modeling.
Life course approach.
Life course approach.
Okay. To be quite honest, I'm not entirely sure exactly what you're referring to, but in the model that I was showing you with the jars, we apply that to the individual in front of us, right? So we don't just talk in broad and vague terms about, here are some environmental factors that can increase vulnerability. We engage in a conversation with the person in front of us, and people love it. They get right in there and they're like, okay, so when I moved house 5 times between the ages of 5 and 10, that could have added some of those triangles into my jar. And so when I had a head injury when I was 7, maybe that added do you know what I mean? So absolutely, we apply that jar concept to the story of the person that we're counseling, and we make it very personal. Yeah.
So maybe I can ask my second question. So what would be the age that we should start this genetic counseling? At which age we should start?
Okay. Oh, thank you. This is a great question.
That is also another way to look at in a life course approach.
Okay. So just to be super clear, I'm talking about genetic counseling as a highly circumscribed and time-limited form of psychotherapy. So in our clinic, we set it up. The traditional model for genetic counseling is that it's one single visit. I wasn't sure that was going to be that's arbitrary. There's no evidence saying that works. So when we set up our brand new psychiatric genetic counseling clinic, we set it up such that we offered everybody the chance to come back in to continue talking about things. What we found is that less than 5% of people take us up on that. They don't need it, right? It's potent because we're addressing an existential issue, but it's because it's so circumscribed, it's not something that we continue longitudinally. We will refer people on for longer term psychotherapeutic work. But to address your question about at what age can you do genetic counseling for people, we work with families in the OCD clinic. For example, we've got a beautiful story about an 8-year-old who had been recently diagnosed with depression, and we were working through the JAR model. It works beautifully for children. And she was sitting there with her parents talking about things that had been happening at school with bullying and so on. And she was talking about, so when that happened, that would have been like a Dorito in my jar, right? So the model is simple enough that it's accessible to people of a whole variety of ages. Yeah. Thank you for the question. Yeah.
Hi, over here. Oh, do you have time for one more?
Final question, yes, please.
Quick one. I'm Heather McKay from the University of British Columbia. I'm over here.
Thank you.
Hi. And you sort of touched on this in your last response, and we know that behavior change does not happen in a vacuum, and it sometimes takes a system, and so I was wondering how you formally engage family or different levels of influence in your behavior change model.
Yeah, so it depends on the individual situation, I suppose. So sometimes it's just the single individual, sometimes it's couples, sometimes it's an entire family. So we really work with the referring physicians around what's the best approach in each given situation. Yeah.
Thank you.
Thanks.